Now I request Dr. Krishnendu to talk about prognosticating macular disorders, medical macular disorders.
Yeah, thanks, Dr. JVN, for giving me the opportunity to speak in this podium in front of sir. So always, whenever you see patient, the patient always asks, what is the outcome? What will be the outcome if you treat? So I'm coming one by one. So first, my topic of discussion is AMD is a vast topic. Till I need to finish it first. So whenever the patient comes either with PD or SRF in advanced stage or early stage. So if the patient comes with this PD and kind of hyperreflective spots, then we have to be very cautious, because otherwise the patient will develop CNVM in future or geographical atrophy in future. So PD, by say, we have to keep them under follow-up. And PD height also important. The patient is chronic follow-up, only the PD, there is no SRF, nothing, no CME. The patient can be followed up. If there is increase in height, the patient can have CNVM later. So in these cases, we need to do OCT angiography in order to visualize the membrane if it is there. But don't have to treat all membrane unless they are presented with the structural B scan. And intraretinal fluid is more ominous. Intraretinal fluid are very difficult to treat. Here the patient needs aggressive treatment than the only subretinal fluid. And the subretinal hyperreflective membrane also a poor prognostic indicator. The patient presenting late, and there is a thick subretinal hyperreflective material which is very difficult to go away. Even if we treat on and on, it keep on persisting. The RAP lesion, if the patient presents with the RAP lesion, very poor prognosis gets signed. If you can see, there is a edema, there is a SRF, there is a PED, everything is there. So the patient, even if we treat with the PDT, repeated injection, the patient outcome will be less. Patient can present with scar. So even if you see the scar, if it is involving the fovea and parafoveal, it can prognosticate the disease. If it is parafoveal, it's a good prognosis than the foveal scar. Degenerative cyst, more important to differentiate between the cystoid edema and the outer retinal tubule which is there. So in the patient presented with the outer retinal tubule with the edema, definitely will not going to do well with the injection. And the large peak PD with the SRF, this patient often we jump to give injection and patient can land up having a RIP. So this is a poor prognostic case with a large PD. The geographical atrophy, we can see the prognostic. If there is away from the fovea, then it's good, but it can involve the foveal region later on in future. So patient can be followed up closely and cautious that this might progress, not to frighten them, but just to let them know. PCV, large hemorrhage, is a poor prognostic indicator. Sometimes they present with peripheral polyp, which can be lasered after pneumatic displacement. This kind of large retinal, subretinal bleed, very difficult to treat. They might need surgical intervention, and sometimes pneumatic displacement often work. Now, another type of disease, there's a CSCR. Now it is being classified as a simple and complex. Before it was acute and chronic. Now this definition recently came into the picture. It's mostly defined by the fundus autofluorescence. That is the 2 disc diameter of RP changes. If it is less, it's simple. It is more, than it's complex. The bad prognosis when the persistent CSCR is there. Subretinal fluid persisted more than 6 months even after you do laser. Outer retinal atrophy, and if the patient presence of bullous RP dip gives a poor prognostic indicator. Like this way, this is large cystic space. Is a chronic CSCR, is a complex CSCR, large cystic space, is a cystoid degeneration, is not going to do well. Next is the outer retinal atrophy. We treat the patient with CSCR that develop outer retinal atrophy. It is again is not going to do well. RP changes. Here the fundus picture, even the red free picture doesn't show well, but if you see the autofluorescence, the area of RP atrophy is huge. So this is the complex CSCR. Again, you can see there's a multiple leak CSCR, multiple leak. Patient is on steroid. We have to stop steroid. And the ICG gives you better indication that how far the choroidal vessels are. There's a multifocal leak CSCR. Here there's a large PD. You can see the pooling of dye here. We have done the laser. And what happened after doing the laser? It ripped. So large peak PD is a chance we can, even after doing laser, it can rip. And bullous detachment, what I have explained. Now coming to MACTEL. MACTEL, though it's very poor, but even sometimes we can prognosticate to see there is a fluorescent angiography showing there's a fuzzy leakage, and the OCT showing there's some clumping in the outer retinal layers. So there's an indication, there's a hemorrhage exudation indication of CNVM. Here you can see the arterial and venous anastomosis here, and there's a clumping of the outer retinal layers. So indication of CNVM going on. This is a publication by Ramesh, which shows there is a pre-proliferative stage of MACTEL, which can be detected by the doing OCTA, where you can see the DCP, there's a crowding of the blood vessel in deep capillary plexus. It is an indication that patient can develop CNVM in future. Now, last topic is the myopic tractional maculopathy, though the cause is little unknown. There's a lot of reason behind it. It can be due to rigidity of the ILM or retinal vascular traction. The problem is often we don't have to treat, but if the patient develops SRF, subfoveal SRF, then we have to treat by doing ILM pilling, sometimes macular buccal if it's a deep-seated eye. Generally, they do resolve by their own. If it doesn't resolve, if there is a foveal detachment, if there is a retinal detachment, full thickness macular hole, then we have to intervene by doing vitrectomy or macular buccal or together. There is a case of myopic maculopathy with a foveal schisis or subretinal fluid, and even if we treat, the subretinal fluid tend to persist for long period of time. We have to wait, and sometimes they develop macular hole. See, this is a case of macular hole with a subfoveal SRF, preoperative picture, and even if we settle the retina, there is a thinning of foveal layer. So the prognostication is a poor outcome. Now, last topic is the blunt trauma. The blunt trauma, always the OCT is helpful. If there is a no change, the only undulation of the external, EZ zone, there's a good prognosis. If there is a defect in IZ zone, intermediate zone, it's a bad prognosis. If they involve the both EZ and IZ, it's grade 3, poor prognostic outcome. And if it develops the external limiting membrane break, then it's further loss of vision. The grade 3 and grade 4, grade 3 where the loss of reflection of IZ and EZ, and grade 4 where the loss of reflection in IZ, EZ and ELM, these are not reversible. Now, surgical intervention of the traumatic macular hole, when to operate. If there is no cystic fluid here in the left side, then this hole is not going to do well with surgical intervention. Only observation will do well. It will close in future. But if it is associated with partial parafoveal cystic fluid in the retinal layer, then it will do well with the surgery. This is a traumatic macular hole with retinal detachment. Is after surgery, it will close, but it can lead to foveal atrophy. Thank you for patience hearing.